Head and spinal trauma. Some of the trauma that will pose the greatest challenge to manage and pose the most significant life threats to your patients can be head and spinal trauma. We also see head and spinal trauma as a component of multi-systems trauma and not just as an isolated head injury. So we have multiple things that we're dealing with at the same time, but we're not learning multi-systems trauma today. We're learning trauma body system by body system. So let's delve into some head and spinal trauma. By now, hopefully you know that the central nervous system is your brain and spinal cord, and that your overall nervous system is very complex, and it's a network of nerve cells that enable your body to function, right? So billions of nerve fibers. And remember, I told you that to picture the spinal cord as being kind of like a cable or a fiber optic cable that's not just one great big nerve, which is kind of, I think that's how it used to be portrayed in these books, and that's definitely not that. There are millions of nerve fibers, billions of nerve fibers in the spinal cord, and it's more like a big cable with sensory nerves, with motor nerves, with everything running within that big bundle. And your central nervous system is fairly well protected. What little brain I have is really well protected because my mom always told me I was the most hard-headed person in the world. My wife picked up the gauntlet and carried that forward after I got married. So apparently I am a hard-headed person. I like to be in control, and I don't change my mind easily, which at times made me a really good paramedic, but apparently it can make me difficult to be around. So that's me. We're not here to analyze me. All right. Spinal cord is protected within the spinal canal that is created within the a foramen that runs through each vertebral body as you stack the vertebra up to build a spinal column. Someday when you're Dr. Frankenstein, I guess, you stack the vertebra up to form a vertebral column. The foramen line up, and the spinal cord runs through those, and it's protected by that bony vertebral body, and then a network of ligaments and then muscles that surround that form that spinal column. If that is disrupted and causes damage to the brain or to the spinal cord, which is in the spinal canal, and that's the word I couldn't find when I kept saying that the foramen that's formed by stacking up vertebrae, spinal canal. That's if there's trauma that disrupts that, we can have damage to the brain or to the spinal cord, or you can have a patient who has damage to both. You know that we have central nervous system and peripheral nervous system. We've talked about the sensory nerves and the motor nerves. Sensory nerve endings, we feel, this guy feels he's holding a ball in the wrong hand. No, I can throw a ball a little bit left-handed, not very well. He feels that he's holding the ball, and that sensation is translated via sensory nerve to the spinal column, and then that sensory pathway in the brain recognizes the feeling of that's a baseball or that's a tennis ball. Obviously, you would need to probably have held it before to be able to tell just by feel what you're holding. But based on knowledge and experience, or knowledge gained from experience, he knows he's holding a baseball. And in order to throw that baseball, his brain has to generate messages to motor nerves that innervate the shoulder, the entire length of the arm, the hand, because the hand is involved in the release point. You build, what do we call it? Muscle memory. We build the memory through this, and you have to, when you throw a ball, you step at the right time, and then you bring your body through in that coordination of body movements. That would also involve the balance center in your cerebellum, obviously. So just thinking about all of that, it's quite a complex ordeal to throw a ball, and then to throw a ball well there's natural talent there, and then there is learned ability that comes from building muscle memory through practice. Anything you do, learning to play a musical instrument, learning to start an IV on a patient, learning to pump up a blood pressure cuff and then unscrew the valve just enough to start letting the air out so that the needle comes down slowly so that you can auscultate and ascertain your patient's blood pressure. Lots of coordination, lots of muscle memory involved. How do we learn how to do that? We practice, right? We practice. Parts of the brain: cerebrum, cerebellum, brainstem. When we're talking cerebrum, we're talking the lobes, so the frontal lobe, occipital lobe, and then the parietal lobes. So we have one frontal, one occipital, and then we have left and right parietal. So those comprise the four areas of the cerebrum, and different things are controlled by different portions. That temporal lobe is part of, actually more part of that parietal lobe, I think. But anyway, different functions are controlled in different places in the brain. I mentioned balance when I was talking about throwing a ball. That would be a cerebellar function, something that's controlled by the cerebellum. And coordinated body movement, that's also involved in throwing a ball, pumping up a blood pressure cuff, and releasing the little valve. That foramen magnum, that is the large hole in the base of the skull where the brainstem exits where the spinal cord exits the cranial vault. And we'll see in a couple of CT scan pictures later in the slideshow why it's important, the importance or the role that the foramen magnum plays in the progression of signs and symptoms of some closed head injuries. Okay, cerebrum, that's those two hemispheres with four lobes. That's 75% of the brain's volume. Okay, brainstem, those are the basic functions of life. The basic functions of life are controlled by the brainstem. What would that be? That would be our heartbeat, our heart rate, our respiratory rate, the depth of our respirations, our pattern of respirations, our temperature control, all of those things are controlled in and around the brainstem. Temperature control is a little higher up than the brainstem. Anyway, spinal cord, it's like fiber optic cable. It carries messages. Remember that there are protective coverings, the meninges, that help protect the brain and the spinal cord. The outer layer, the fibrous, really tough sac-like structure that surrounds the brain and the spinal cord, the dura mater, the arachnoid mater is in the middle, and then the pia mater is on the surface sits on the surface of the brain, and the spinal cord, we have pictures of that. So skin, then skull is this. Okay, skin, then muscle. Muscle is that kind of pinkish layer, then skull, that's the bone there. Then we have the dura mater, that bluish color streak running around there. That is that fibrous outer sac-like structure that covers the brain and spinal cord to help protect them. The arachnoid mater, you'll notice, has they put arteries and veins in there. So in the proximal, because it's the closest to the midline of the body, and the most proximal portion of the arachnoid mater is where those arteries and veins run, and we'll see the significance of those in certain types of head injuries here in a few minutes. And then the cerebrospinal fluid circulates between the arachnoid mater and the pia mater. And again, that pia mater it folds into all those crevices of the brain, as all those folds of the brain tissue, and then down the spinal cord. CSF, it's produced in the third ventricle of the brain. I'll show that to you in a CT scan in a few minutes. There's about, in an adult, up to about 150 milliliters of CSF bathing the brain and providing a cushion for the brain at any one time. It acts as a shock absorber. Have spinal nerves exit the spinal cord at each vertebra, kind of like that. Note that you have a plexus of nerves, the lumbosacral plexus there, and then the brachial plexus up here. Really complex network of nerves. Then we've talked about the cranial nerves before. They transmit information directly to the brain. They don't involve the spinal cord. So that's more ready, instant information to the brain. There's the list. I'm not going to make you memorize those in this class. You'll have to memorize those in paramedic school or in human anatomy and physiology. This little chart in this PowerPoint, which you have available to you in Blackboard. If you just needed something to do because you had nothing else going on at this time of the summer, then you could take a look at those. Have sensory nerves, motor nerves. We talked about those briefly a moment ago. Information going from the body to the brain is conducted along sensory pathways from the peripheral sensory nerve endings, up those sensory nerves to the spinal cord, and then up to the brain to interpret. Motor nerves go from the brain out to and down the spinal cord and out to the muscles via the nerves that innervate those particular muscles, and you have one for each muscle. Connecting nerves, those are only in the brain and within the spinal cord. And those are a direct connection of sensory and motor nerves. The big place that we see those come into play, one of the big places is reflex activities. The put your finger on a hot stove, and you don't have to think, I need to move my finger, and because you got that sensory message in your brain, and then your brain sends a motor message down via the spinal cord and out to the right muscles to move your hand. That reflex arc makes its way to the spinal cord, and then via these connecting nerves sends the information right back down so that you withdraw your finger like that. Hot candle, that's hot. Doesn't have to go to the brain. It makes it here. The sensory message hits the spinal cord, and then bam, the motor message goes right back down to move the hand. Voluntary activities we intentionally perform. Involuntary, our body performs without conscious control. Voluntary, that's controlled by the somatic nervous tissue. Then autonomic, that's involuntary. That handles involuntary functions. That's divided into sympathetic, parasympathetic. Hopefully that sounds really familiar. Sympathetic is fight or flight, and parasympathetic is rest and digest, which is the opposite of fight or flight. And in a properly functioning human, I better say that slowly, or I will say something I shouldn't say. In a properly functioning human, you have a constant balance of sympathetic and parasympathetic nervous systems working together to maintain homeostasis, right? We've already talked about the skull. It hasn't changed in an hour. 80% of the inside of your cranium is occupied by brain tissue, 10% by blood supply, 10% by CSF. The parietal bones, your occiput, your temporal bones, your parietal bones and frontal bone make up your cranial vault. I don't like that slide. It contradicts itself, and it's unnecessary information right now anyway. Okay, you know what the vertebrae are by now. I'm not going to ask you a question of how many are there, but you need to know how to palpate C7 for me, and you need to know roughly where the thoracic vertebra end and the lumbar begin, and what the lumbar region is and what the sacral region is. We're not going to get real hung up on that topical anatomy other than the things that I've just mentioned. Injury to the spinal cord can result in paralysis, and that paralysis can be permanent. We don't know on our end whether it's going to be permanent or not. They have improved slightly in the treatment of spinal injuries in the last 30 years, so that some things some spinal injuries are more treatable now than they used to be. How do we treat them? We treat them with potential spinal injuries with complete spinal immobilization, right? That begins with manual C-spine, and then we apply a C-collar and a backboard with a CID and appropriately applied straps to stabilize that patient, and then we've done what we can to protect their spinal cord. Head injuries, more than half of all traumatic deaths. That's a lot of dead folks. 52, in excess of 52,000 a year. This says at the time of the printing of this book, which was probably like 2013-ish. I can't remember for sure. It doesn't matter. The numbers have changed. They will be updated when the new edition of this book comes out in 2 or 3 more years, probably. All right. Things to consider when your patient has possible spinal injury. They may also have pelvic injuries. They may have chest injuries. We need to do a good trauma assessment so that we can appropriately make that determination and err on the side of caution, overtreat, and provide. It's better provide. And we have protocols now so that not everybody gets a backboard. They may just get a cervical collar and be placed on our stretcher, and we're supposed to make sure that they don't have excessive movement and that kind of thing. But that hurts my old paramedic brain to think of having anybody on a stretcher with a cervical collar without complete spinal immobilization. Protocols differ from place to place. Know your protocols, learn your protocols, follow them. That's what your medical director expects you to do. What would I tell you? If there's a question in your mind, then err to the side of caution. It's better to apply a backboard CID and C-collar 10 times too many, and rather than miss the one time you should have done it and didn't. So head injuries, very common MOI would be motor vehicle collisions. Assaults are another big, what am I trying to get to? What am I trying to say? Statistically, a large number of elderly people who have head injuries suffered those head injuries with a fall being the mechanism of injury. So in your elderly folks who suffer falls, be sure and assess them for signs of head injury. And then other sports related incidents. Traumatic brain injury, we every year during football season we hear a lot about repetitive brain injury and the chronic depression that may be caused from that, and the suicide attempts, all those things. Signs and symptoms of a head injury, I'm not going to read them to you. You need to familiarize yourself with these. We will talk about some of them as we work on through this, but you need to be really familiar with that little table there. Scalp lacerations, as I said in the previous lecture, those bleed considerably. It is possible to have a large enough scalp laceration that can cause enough bleeding so that your patient goes into hypovolemic shock. That would be rare. Usually you're able to control that bleeding, and usually your patient does not bleed enough to have to to suffer hypovolemic shock. I can't talk. What would we see if our patient was hypovolemic and they were shocky? We would see the compensatory mechanisms kick in, right? We'd see the heart rate go up, respiratory rate go up, and level of consciousness can be affected, and then your patient can be pale and diaphoretic with weak peripheral pulses, painting a pretty good picture, I hope, of a patient with suffering hypovolemic shock. Head injuries cause signs and symptoms opposite of hypovolemic shock. So if you have a patient with head trauma and they have signs and symptoms of hypovolemic shock, we need to treat for that hypovolemia. And it doesn't mean they don't have a head injury, but that is not the life-threatening condition that they're presenting with at the moment. Ouch. That is an avulsion. That is a significant avulsion. I cannot tell you what caused that. I just went and Uncle Google helped me find this picture, and it was dramatic enough that I thought I could make a couple of points using this picture. One would be that is an avulsion. That is the muscle and some of the fat tissue of the scalp. That is the skull and the periosteum, the fibrous kind of lining that goes over the bone. So that's what we're looking at there. Probably have cauterized with electric cautery. Probably cauterized the large vessels that perfuse that part of the scalp, because there's no bleeding here to speak of. He doesn't look dead. It took a significant MOI to cause that major avulsion, right? So we need to be concerned. We need to have a high index of suspicion that this patient has closed head injury, and manage that appropriately. I would also maintain that it took significant enough force to cause that large avulsion that this patient may have cervical spine injury. So if I have him as my patient in the street and I don't have x-rays available, I am going to immobilize his C-spine. I'm going with full spinal immobilization on him and transport him, irrigate under here, fold that flat down, put a big sterile dressing on that, and put a pressure dressing on that. After I fold that flat down and get a sterile dressing over that, I could go ahead and palpate to see if I feel any crepitus, any crunchy bone that would indicate to me that there's a large skull fracture there. So those are things that you consider just off of that picture. Things I need to assess. Does he have equal pupils? Does he have any blood coming from his nose or his ears? How would I know if that had cerebrospinal fluid in it? I'm going to take a piece of 4x4 gauze. I'm going to get some of that fluid on it, and I'm going to take that piece of 4x4 gauze, lay it aside, and I'm going to keep working my call. And here in 5 or 10 minutes, I might be able to look over and see if that had separated out into kind of concentric rings. It kind of gets, actually not actually concentric rings, it kind of separates out into an appearance so that it's darker in the center, and then as it spreads out, it gets lighter and lighter. And that's that would be a positive halo test. If that starts dark in the middle, and as it spreads out, it gets lighter and lighter and lighter as it spreads out. So we need to do a halo test if he has anything coming from his nose or his ears. We could ask him if he notices any kind of unusual taste in his mouth. He could say popcorn. If he says popcorn, then that might tell me that he has an altered mental status, which would be indicative of a closed head injury, and we'll talk about types of closed head injuries in just a moment. Skull fractures can be closed, they can be open. Closed, so if this is open, you have this big avulsion, and let's say it's obvious. We can see that there's a fracture there. You can see this bone is just shattered all to heck, or maybe you see a long line and along that line it's spread apart, so that's really obvious to you that there's a break there. Would that be an open head injury or a closed head injury? Because the scalp is open, we're going to call that an open head injury. They're going to determine at the hospital if this opening extends through and into the skull, into the cranial vault, and then that they might call what we might call an open head injury pre-hospitally. They might call a closed head injury in the hospital because they have the benefit of x-rays. Open head injuries, I've seen them from bullets. I've seen them from knife wounds. I've seen the flat end of a claw hammer impaled in somebody's skull. They weren't a patient; they were a dead on the scene. But that was an open skull fracture. It was obvious that the skull was fractured. There was the flat end of a hammer stuck down through the skull. It took a tremendous amount of force to cause that trauma to that head, and it brought about the demise of my patient who was found early on a Saturday morning. That was a great way to start my day, but I had a better day than him and his family, so I guess I can leave it at that. Bullets, yes. All kinds of things penetrate the skull. Rebar, gear shifts in cars without, like a floor shifter of a manual shift without the knob on top. They put the knob there for a reason. So if somebody's flying around inside of a car, they don't stick a gear shift through themselves. That's an ugly sight, I promise you. So what would signs and symptoms of a skull fracture be? Keep talking about these amazing skull fractures. How am I going to know when I find one? Patient's head appears deformed. Our problem is we don't have a frame of reference. Maybe their head's always whopper-jawed and deformed. We don't know that. So if it appears to be deformed, either when we visualize it or when we palpate it, if it's deformed, then we're leaning toward possibility of a skull fracture. Visible cracks in the skull, that our guy back there in that picture, if we could see a long linear fracture here, or if we see that shattered glass kind of appearance of a crushing fracture, otherwise called a comminuted fracture, then that would be a sign of a skull fracture. Raccoon's eyes would be a sign of a basilar skull fracture, as would Battle's sign. So what do those look like? Oh man, I have a picture. Raccoon's eyes, Battle's sign. Behind the pinna of the ear, there's a bony prominence that you can find. It's a large bony prominence. That is your mastoid process. Well, there's half the equation. You know how to find it on yourself. Now you can go find it on someone else. And if you find that bruising, that battle sign, that bruising around the mastoid process, or mastoid ecchymosis, or this is periorbital ecchymosis, is what raccoon's eyes is, the proper name for it is. Those are indicative of a basilar skull fracture. But I'm going to tell you that's not a lot of help for us in our world unless we get somebody who has an multiple hours old injury. We're not going to see this pre-hospitally. It takes hours for these to develop. Now, if we have an elderly person who suffered a fall, like maybe this lady did, I don't know, and maybe she struck her head, or he, I don't know, I can't tell from this picture, but this person, we could have a patient who has this appearance when we arrive on scene, and they've suffered head trauma yesterday. It's been 12, 14 hours ago, and we might start seeing this periorbital ecchymosis, raccoon's eyes, or battle sign. And if it's an open basilar skull fracture, that's where you would have CSF leakage from the nose, from the ears, and possibly into the mouth, through the roof of the mouth, and get that CSF in there and have that real sweet taste. 80% of skull fractures are linear skull fractures. Without x-rays, we're not going to be able to diagnose that. We don't diagnose anyway, but we're not going to be able to determine this pre-hospitally. Could be that the brain's uninjured and there's no scalp laceration, and this isn't life-threatening, and maybe later down the road they're told, when did you have a head injury with a skull fracture? I don't think I ever did. You ever had head trauma? Well, I mean, I hit my head really hard one time. Well, did you have a really bad headache? Yeah. Did you have a lot of swelling there? Yeah, I had that. And did it hurt really bad? Yeah. Did you lose consciousness? Well, not completely. I think I just kind of got my bell rung, and then I was all right. And so that, okay, so that's that might be a skull fracture that was missed. Depressed skull fracture, or if you imagine this just shattered like an egg, just like you take a hard-boiled egg and hit it on the table and it just shatters all over the place, that would be a comminuted skull fracture, and you have a lot of little bone fragments that could be pushed down into the brain. Depressed skull fracture, it could be just one big chunk of bone of the skull that's broken and forced down into the skull. So that would be a high energy mechanism of injury, and you could expect widespread brain trauma from that, not just in the area where that bone fragment is pushed down into the brain. Basilar skull fractures I've talked about quite a bit already. It's a high energy trauma, diffuse impact to the head, and signs include CSF draining from the ears. Now you know how to determine if it's there. You do that halo test, just like your book says. Sometimes the book to some people, can give the indication that that's an instant test, and boom, I know that I'm dealing with cerebrospinal fluid, and that isn't the case. It takes time for that to separate out. In the advanced class, we'll teach you that you can take a glucometer like you use to get a BGL from someone's finger, and you can get a glucose level of that discharge from the nose or the ears, that liquid that you suspect to be cerebrospinal fluid. it has a different glucose level than the blood glucose level. It's lower than the blood glucose level, but it definitely has a, if it's blood that's coming out of the ears or the nose, it's going to have a higher blood glucose level than cerebrospinal fluid, and cerebrospinal fluid is going to have a glucose level, whereas if you just had watery fluid coming out that wasn't CSF, it's going to have little or no glucose level. So that is a possibility down the road. That's not even mentioned in your book, so don't even worry about that yet. And then delayed signs of a basilar skull fracture would be raccoon's eyes and battle sign. Open skull fracture, sometimes if you have a laceration with head trauma, treat it as if it's an open head injury. Sometimes you'll be able to see gray matter. You'll actually be able to see brain matter and know that you're looking at it. Sometimes it's just hidden down in there in a mesh of hair, and so you wouldn't have any trouble finding it on me because there's no hair to speak of. So that requires considerable force. Quite often you're gonna find skull fractures in conjunction with trauma to other body systems. So you're gonna have a patient with multi-systems trauma. Traumatic brain injury, that is a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, and vocational changes. So that head trauma, let's say the one you hear about on commercials is you hear about soldiers who were victims of roadside bombs in Iraq and some in Afghanistan, and where they were just normally functioning human being soldiers before. After that blast wave causes that brain injury, they suffer from emotional outbursts. They suffer from chronic depression, maybe even to the point of having suicide attempts. Quite often, military folks who attempt suicide are successful because they use a high velocity projectile that causes penetrating brain trauma to effectuate that suicide attempt, and it becomes a suicide success. But it could be just an attempt. But so physical changes, you'll see people who after a traumatic brain injury, they have a real halting, unsteady gait when they walk. They walk like someone who has cerebral palsy walks. And cerebral palsy quite often is from either a cord incident where the baby gets in a position in utero so that the umbilical cord is crimped for a little while, causing a hypoxic insult, or there's a traumatic birth injury that causes the baby to have a hypoxic injury to the brain, which causes kind of spastic movements. And by I don't mean clumsy. I don't mean the slang word of spastic. I mean like uncoordinated, jerky muscle movements are in medicine are spastic movements, and you see those spastic type movements, and a lot of times that somebody they'll after their head injury, they'll have a lot of trouble with balance and with having a smooth gait when they walk. They're unable to do their job anymore. You can picture the most amazing cardiothoracic surgeon in the world, and let's say that kings and queens and presidents and prime ministers and billionaires all want this cardiothoracic surgeon to come handle their surgery, or they travel to come see this surgeon for their surgery. And on the way home from the hospital after a 22-hour surgery, that surgeon is involved in a car accident and has a closed head injury, and now her hands don't work right, and her arms don't move correctly, and her vision is different, and she just lost her vocation. She may have just lost her identity as a person. Maybe every fiber of her being is tied up in being the world's best cardiothoracic surgeon. I don't know how you determine who's the best, but let's say one of the best. And so that, yeah, just that long can be a game changer for someone. Look down to read a text. Maybe that doctor left the hospital and driving home, and they get a Tiger text, which is an encrypted text that complies with HIPAA, and gets a Tiger text saying that patient's starting to crash, that you just did the 22-hour brain surgery on, come back to the hospital, and in the time they look down at that text, they're involved in, they run under a semi-trailer and have horrible head trauma themselves, and everything, maybe they live, but everything changes. And so you can see what the effects of a traumatic brain injury could be. It can have primary effects and secondary effects. So instantaneously from impact, gunshot, self-inflicted gunshot wound to the head has an instantaneous effect on that brain from that projectile leaving the muzzle of that gun, leaving that barrel of that gun and entering the head. If you have, let's say, blunt force trauma to the head, boom, you have the trauma, and it causes a slow venous bleed in that very proximal portion of the arachnoid mater, and that starts to compress the brain, and that increases intracranial pressure, and that brings about certain signs and symptoms. Those would be secondary brain injuries. Secondary injury could also be caused by hypoxia. So your patient is in respiratory arrest for a period of time, and they don't perfuse their brain, and they have hypoxic injury to the brain. You have brain cells that die. That's a secondary brain injury. Hypotension that doesn't perfuse the brain. Same thing, cerebral edema that compresses part of the brain so that it can't be perfused. Intracranial hemorrhage, increased ICP. We'll talk, ICP is intracranial pressure. So that increased pressure decreases blood flow to the brain, which causes hypoxemia, causes the brain not to be perfused. So you get that secondary injury. And then infection, you could have an abscess of the brain tissue itself. You could have infection of the meninges, so meningitis, that causes a secondary injury to the brain. Coup contra coup injury, head hits windshield, brain is compressed against, let's say, the frontal portion, the frontal skull impacts the windshield, head hits the windshield and comes to a stop, and the brain moves forward until it impacts the inside of the skull. So there's the coup, that loading, that compression of the brain against the frontal skull. Then the head slams back against the headrest, and then that process works backwards so that you get then that rebound effect plus the head stopping when it impacts that headrest, and that compresses the brain posteriorly. So you can have a patient that has injury to the frontal lobe of the brain and the occipital lobe from that coup contra coup injury. It can take time for the brain to swell, that cerebral edema that can decrease blood flow and decrease oxygenation. And cerebral edema can be aggravated by poor perfusion of the brain. So if our patient is hypoxic, they have low blood oxygen levels and they're not perfusing the brain, and you have an accumulation of CO2 in the brain, that high carbon dioxide level and low oxygen level also causes cerebral edema. So you could have some cerebral edema from the impact, and if that causes your patient to develop one of the a breathing pattern so that they're not ventilating appropriately, so that then alveolar respiration can take place, so you have that CO2 buildup. They can also have cerebral edema just from that. Or your patient who is in cardiac arrest and they've been down for a little while, a few minutes, and then you start CPR on them, and maybe you throw the AED on them and you defibrillate them, and they go back into a perfusing rhythm and they start perfusing their brain. They have still had a hypoxic injury to their brain, which can cause cerebral edema. And quite often, if we're successful in resuscitating someone and they're in a critical care unit in the hospital, they may be receiving corticosteroid medications to help decrease that cerebral edema. Increased intracranial pressure, so ICP. This is from my advanced class, and I'm going to go through it really quickly because I think it makes a point of how increased intracranial pressure from a closed head injury causes our patients not to perfuse their brains. So mean arterial pressure, you've heard me talk about before, and I told you that's more important than just systolic blood pressure by itself. And normal MAP, mean arterial pressure, you don't have to learn this yet, but normal MAP is 70 to 110 millimeters mercury, and even down as low as 60 millimeters mercury. Perfuse your brain and your internal organs for a period of time. Normal intracranial pressure is 5 to 15. So let's look at this cerebral perfusion pressure. That tells us how well brain tissue is being perfused, and that it incorporates the pressure within the cranial vault itself, that ICP. Let's say that, and we have to be able to perfuse the brain, so we have to have a sufficient systolic and diastolic blood pressure to get that minimum of 60 and then maybe up to 110 millimeters mercury of mean arterial pressure to generate the 70 to 80 in cerebral perfusion pressure that's needed to perfuse the brain. And if, let's say, we can't measure ICP pre-hospitally, but if it was 45 and the MAP was in normal range, that creates a perfusion pressure within the brain that's higher than that mean arterial pressure, which would mean what? We're not perfusing the brain. So that's the point. That's the reason I put this slide in here, is to show you that if the pressure is high enough, if the intracranial pressure, ICP, is high enough, the brain is not going, it's not going to be perfused because the heart is not going to be able to generate sufficient pressure to move oxygenated blood into the brain so that respiration, cellular respiration, can take place within the brain so that oxygen is offloaded in the brain, oxygen and glucose, and then carbon dioxide is removed. So hopefully you can see why that matters. It's not something that we're going to be able to really assess that much pre-hospitally, but maybe that gives you a word picture of what's going on inside that head as we see the signs and symptoms of increasing intracranial pressure. Signs of increased intracranial pressure. Shane Stokes respirations. That is, oh, where do I have Shane Stokes? All right. So these up and down lines, those are the depth of respirations. So the deeper the respirations in and out, the longer those lines are. These flat parts, those are periods of apnea. So no breathing is happening there. So Shane Stokes respirations come out of a period of apnea, and then the rate and depth of respirations start slow and crescendo, just like the music building up to a real loud dramatic point. It crescendos up to these real deep, really fast inhalations and expirations, and then just like music, the drama's going out. It's getting quieter and less exciting. So they have that decrescendo, and then the apneic phase, and then that happens again in the apneic phase. Or it could be that your patient has, they have a head injury and they have central neurogenic hyperventilation. They're just in and out really fast. These are all unusual breathing patterns that your book doesn't even talk about, but BIOTS, it talks about you have deep inspiration and expiration, fast and deep, and then a period of apnea. How is that different than Shane Stokes? They don't start shallow and then get really deep and then get shallow again. So that's what those are. That's Shane Stokes and BIOTS or ataxic respirations. And then you'll see decrease in heart rate, headache, nausea, vomiting, altered mental status, that decreased alertness. Then eventually you're going to see bradycardia, sluggish or non-reactive pupils, decerebrate or decorticate posturing. I think did I lay down on the table and demonstrate that to you in lab? Look up, just Google decerebrate posturing, Google a video and it will show you, and then Google decorticate posturing and find a video that, and so you can see what those are. That's a whole lot better than me describing it to them. And then Cushing's reflex we'll talk about in just a minute. So those are signs of increasing intracranial pressure. Bleeding inside the skull. So swelling of brain tissue can increase intracranial pressure. Bleeding inside the skull can also increase intracranial pressure. It could be between the skull and the dura mater. It could be between the dura mater and the outside of the brain. It could be within the brain tissue itself. What does that look like? It could be that there's a hematoma here on the surface of the brain, but below the bone. And as blood accumulates there, it compresses brain tissue further and further and further. And then we see those signs and symptoms start to develop that we talked about. Epidural hematoma versus subdural hematoma. Subdural hematoma is venous bleeding. It develops more slowly. An epidural hematoma is an arterial bleed, most often caused by a tear of the middle meningeal artery. You know where your temple of your skull is. Right there in that temple area is where the middle meningeal artery lies. And if that's torn or ruptured, that causes bleeding, that compresses brain tissue, and that brings about those signs and symptoms. So here is an epidural hematoma. You see this line right here between the right and left hemispheres of the brain. That should not be bowed in like this. So you have bleeding here. Actually, the right on this one is there. So you have bleeding on the patient's left. That arterial blood is accumulating. It's displacing brain tissue. We have a shift across the midline. It's compressing the ventricle, which further raises intracranial pressure. The ventricle should be a little triangle shape there. You can't even see it. So there is that ventricle. Subdural, you just have that accumulation of that dark venous blood that starts to compress that toward the midline. That's a pretty significant subdural, but it develops much more slowly. We don't diagnose these pre-hospitally. It takes a CT scan and then maybe an MRI to be able to see these. Okay, we're running down to the last 15 minutes and we're on track to finish on time. Okay, I told you earlier when we had a picture, this is an MRI, but when we just had a graphic representation of a brain, I told you that the foramen magnum was important and that I would tell you why that was relevant in a patient with a closed head injury and increased intracranial pressure. And then I'm going to tell you after this the signs and symptoms that go with this. This is normal. This is the brain stem coming down here. Spinal cord comes out here. Brain stem coming down right here. Right there in the base of the skull is where the foramen magnum is. Again, we have a two-dimensional lateral representation of that. Now let's move over here to the abnormal picture. We have increased intracranial pressure. See how this dark spot is much larger on the left, but here it's kind of more gray colored and it's compressed. Now this is the cerebellum down here. Over here, this is the cerebellum. The increased intracranial pressure over here is forcing the brain. The pressure is causing the cerebellum to put pressure down on the dang it, I just lost it. What do I call that structure? Okay, you have pressure pushing this structure down. Somebody help me. I lost the word. Where did it go? Lord, that is the cerebellum. The cerebral cortex up here, this occipital lobe, is putting pressure on the cerebellum. That's what happens when you try to hurry. And see this little tip right here? It gets pushed down. Now look what happens to the brainstem. This is the foramen magnum. This piece of the cerebellum gets pushed down through the foramen magnum, and it compresses the brainstem. What does the brainstem control? It controls heart rate, it controls respiratory rate, it controls the depth of respirations, the pattern of respirations. So if we're seeing signs and symptoms in our patient that show us that there's a change in heart rate, that there's a change in the respiratory rate and the respiratory depth and the respiratory pattern, then that tells us that our patient has a significant enough increase in intracranial pressure that they have a brainstem herniation, or the cerebellum is being pushed down through the foramen magnum. It's compressing the brainstem, and it's causing those signs and symptoms that we're going to see. CSF flow is obstructed. That increases pressure. That causes further compression that causes the cerebellum to be pushed down even more. You have decreasing level of consciousness that moves toward a coma, meaning you can't arouse that patient. You can't wake them up. You have pupil dilation ipsilateral. That means on the same side as the herniation. So you have unequal pupils. You have one pupil that's dilated and the other is more normal. You have decerebrate pulse posturing. That's where the patient kind of, there's like a full body spasming, and the hands curl in toward the core, toward the midline, and the feet point, the toes point down and out. So, and then you start to see a compromise in the patient's respiratory pattern and eventually respiratory arrest. And then you have death secondary to a respiratory arrest. You also see, with increasing intracranial pressure, you see Cushing's triad develop. The easy way to remember Cushing's triad is it's the opposite of compensated hypovolemic shock. We already know hypovolemic shock and compensation, right? What do we see in hypovolemic shock? We see falling blood pressure, elevated heart rate, elevated respiratory rate. So with Cushing's triad and that increased ICP, we see increased systolic blood pressure, decreased pulse, so they become bradycardic, and they become bradypneic. Their respiratory rate is all decreases. That's Cushing's triad. Concussion is it's a closed type of head injury with temporary alteration of brain function, including it could include a loss of consciousness. That'd be about 10%. About 90% don't experience loss of consciousness, but we don't see the physical damage to the brain that we just spent 20 or 30 minutes talking about. What do we see? We see confusion. They may have retrograde amnesia, meaning they don't remember what happened right before the blow to the head. It usually lasts for a short period of time. We need to also look for these signs and symptoms. You don't have to have all of them. They'll have some of them. It'd be very rare that you'd see all of them. There's some continued ones. Something I'll tell you, if somebody has a concussion, let's say they're playing a sport and they have a concussion, they need to be held out of that sport and held out of any other physical contact until they're evaluated by a physician, because back-to-back concussions prior to healing from the first concussion can that second concussion can result in it can be lethal. What you see there, you have somebody who's already had a concussion, let's say, and they're playing football. They get a blow to the head and they get their bell rung. They're really good about assessing for these things now, but years ago, you got your bell rung, you come out of the game for a minute, they'd take some ammonia inhalants, put under your nose, clear your thinking, put you right back in the game, and then you have that second blow to the head, and that second concussion causes such a major disruption to brain function that the brain just quits and the person dies. It just totally overwhelms the brain. It's more complicated than that, but I want to tell you about that secondary concussion, that second concussion that can have those lethal effects. Contusion, that's like a bruise to the brain tissue itself. So cerebral contusion is very serious. It may require surgical intervention to deal with it. Spinal injuries can have compression injuries. Remember, we've talked about those falls from a height where somebody falls 20 feet and they land on their heels, and that compression causes a compression fracture. It causes a compression injury to the spinal cord. That would be one. Axial unloading. So somebody is restrained in a vehicle and they hit a stationary object and their head goes up and it hyperextends their spine, and that can stretch and tear and rip and transect nerve fibers within that spinal cord, and that can be a catastrophic thing. Rotational injuries can do the same thing. Hanging, that can, if somebody decides they want to do a good job of hanging themselves and jump off the house with a real noose tied around their neck and the rope tied to a tree, and they have that hyperflexion, that overextension injury. Depends on how far they fell before the slack came out of the rope. They could just have some cervical spine damage. They could have and it could just be ligaments stretched and muscles stretched, or it could be a spinal cord injury up to the point that the spinal cord is snapped and they die. Hangman's fracture, fracture subluxate, C1, C2 fracture subluxation is a Hangman's fracture, transects the brain stem, and that is instant death, and there's no recovery from that. Okay. Spinal injuries for assessing for spinal fracture. You're palpating along the spinous processes. They're in line. Everything's nice and straight, nice and cool. And then you find a step off. That would be a spinous process, the pointy part that you feel along the quote unquote backbone, and it's out of place. It's a step off. It goes over and then it comes back into alignment. You need to provide full spinal immobilization. Be very careful. Smooth ride to the hospital. They need some surgery to fix that. We're going to always suspect head and spinal injury with motor vehicle collisions, car pedestrians, falls, blunt trauma, penetrating trauma to the head, rapid deceleration injuries, hangings, axial loading injuries. That would be being maybe even restrained in a rollover accident in a vehicle, and the top of the patient's head strikes the roof of the car, and that causes an axial loading injury. Or diving into a swimming pool and striking the top of the head and compressing the cervical spine. That's an axial loading injury. Okay, and then Tell you what, I'm going to go on the rest of the way through this. It's 11:30. I'm on your time. I'm on your time. I'll record the rest of this, and if you want to hop on my YouTube channel later, you can watch the tail end of this, or you can just go with what's in your book. You can hang around for the rest of the lecture if you want. But we need to investigate chief complaint. We're going to use sample history and OPQRST to do that. We need to get a good baseline set of vitals, including Glasgow Coma Scale, and then we're going to trend the GCS, and we're going to trend our vital signs. How do we know if Cushing's triad starts to develop? We're going to know that working off of our baseline set of vitals and then our serial vital signs, meaning we get that every 5 minutes we get another set of vital signs, and we watch for elevating blood pressure, decreasing pulse, decreasing respiratory rate. That's Cushing's triad, right? That tells us something. That tells us that that ICP is going up. So that tells us, and it may be that then if we start to see one of those funky respiratory patterns develop and we see unequal pupils, then we're starting to see that brainstem herniation, and our patient is headed toward death pretty dang quickly. So we need rapid transport, and they need definitive care quickly. It could be that they just that a neurosurgeon drills some burr holes. They drill some holes through the skull to release some of the pressure, and it may be that they put a shunt in, it's kind of a, they drill a hole in the skull, and then they screw in this stopcock valve, and they can release pressure as needed. You have to have intracranial pressure, so they don't just constantly keep it all off, but they have an ICP monitor, and they monitor that pressure, and they try to keep it in that 5 to 15 range. Okay. GCS is, we assess that based on eye opening, best verbal response, best motor response. You can take 5 different people who are good clinicians, and they assess the same patient at the same time, and you could well get 5 different GCSs. What tells me, what gives me a really good indication of my patient's condition, their mental status, their level of consciousness. If that is changing, that's deteriorating, they have a diminishing level of consciousness, then there is something going on in their head, and it's not something good. So, but with GCS, we say less than 8, intubate. That little rhyme, even though you're not to the point of your career where you're going to intubate, you can remember that little rhyme pretty easily. And if your patient has an 8 or less, that is severe neurologic dysfunction, and we need ALS on the way right now. We need rapid transport, and we'll meet ALS on the way, but we're not going to stay and play. We have a critical patient. Okay. What do? We're going to do the same thing as always, ABCs, right? Have to maintain that airway. We have to ventilate that patient. What if that patient, we don't have ALS available for a long time? We can ventilate that patient. We can, after we contact medical control, even at the BLS level, we can contact medical control and talk to online medical control about controlled hyperventilation of the patient. That doesn't mean we're bagging as fast as our hands will go. That means we push that rate of bag assisting our patients, that push that rate of positive pressure ventilation up to about 20 a minute. That's not that fast. That's once every 3 seconds. 1, 1,000, 2, 1,000, 3, 1,000, 1, 1,000. That's not super fast, is it? People hear controlled hyperventilation, and they want to ventilate their patient 100 times a minute, or 60 times a minute, not 100, but one every second. They want to go that fast. No, it's one every 3 seconds in an adult would be your rate for controlled hyperventilation. What does that do? That helps keep that carbon dioxide level lower in the brain, which helps decrease cerebral edema, which helps lower intracranial pressure. And remember, I talked about cerebral perfusion pressure. If we decrease the intracranial pressure in our patient, then they're going to be able to perfuse their brains more easily, right? So that's what we're after there. Remember, if your patient has a head injury and potential spinal trauma, we're always going to use the jaw thrust maneuver to open the airway. Always keep suctioning available. Provide supplemental oxygen to your patient who has a head injury. Remember, shock is usually, unless you have neurologic shock, in that case, you have an overwhelmed patient who is very unlikely to make it anyway. But if you have a patient who presents with hypovolemic shock, and you know what that looks like from those lectures, hypovolemic shock, you have increased heart rate, increased respirations, they're pale, they're diaphoretic. That is compensated hypovolemic shock. If they present that way, you're dealing with hypovolemic shock. You're not dealing with the effects of a closed head injury. You have a critical patient and you need rapid transport to a trauma center. Cushing's triad, we already spent quite a bit of time on. Remember, if we find that, we're going to provide controlled hyperventilation. That's positive pressure ventilation, a rate of 20 per minute is all. Wet and sticky in 8 years, protect yourself from it. So standard precautions: manage C-spine, assist respirations as needed, and provide supplemental oxygen. If you suspect that your patient if they have facial trauma and you suspect a skull fracture, then we're not going to use a nasopharyngeal airway. It is contraindicated. We're going to be left with an OPA, and if we're having trouble maintaining an airway with an OPA, or man, I got sidetracked. If our patient won't tolerate an OPA, we need ALS to paralyze that patient and intubate them, because we can't take them in without managing their airway. So call ALS, get them there. They'll administer the appropriate IV drugs to paralyze them and intubate them. And sedate them too. It would be quite scary to be paralyzed and intubated without being sedated, so that to make sure you didn't know what was going on. Okay. You know how to immobilize the C-spine. I'm going to bounce right on through these. We've done it all semester. Vacuum mattress, that's what they look like. They're very expensive. They tend to want to cut those off at the hospital, so services tend not to buy those, but those provide the best spinal immobilization, because it vacuum means that you suck all the air out of that mattress, and then it conforms to all the cracks, crevices, and creases of your patient. It contours to their entire body, and it provides the best possible spinal immobilization. You're just unlikely to have them. Sitting patients, you know how to use a short spine board. You also know that if your patient has anything other than an isolated spinal injury, if there's any chance that they're a critical patient, we're not going to mess with that thing. We're going to use a rapid extrication and apply the longboard, and we're going to scoot. We're not going to stay and play with those. It is possible to apply a backboard with the patient standing. We used to always teach that. It's in your book. Here's some pictures of how you do it. More likely these days, you're going to place the backboard on your cot. You're going to put a cervical collar on your patient while they're still standing, and you're going to assist them in sitting down, and then you're going to rotate them around. One person is going to stabilize the head. Another is going to move the shoulders around, while somebody else brings the feet around to rotate them and get them lined up on the backboard, and as you bring them to a supine position as you turn them around. So that's more likely how you're going to do it. You've used that little devil before. You will rarely, if ever, use that in your pre-hospital career. You've used that, you know how to do it. Helmet removal. We teach helmet removal in pre-hospital trauma life support class at the end of your advanced EMT semester of paramedic school. So we leave a helmet in place if it fits well, if there are no potential airway or breathing problems, and if it doesn't interfere with our assessment of our patient, management of their airway and ventilating them, and if we can properly immobilize their spine. So football player has, they have potential head and neck injuries, and we're going to transport them. If we leave the helmet in place, we leave the shoulder pads in place, because that keeps them in alignment, their spine in alignment. But if we're going to remove the helmet, we also have to remove the shoulder pads, because removing the helmet without removing the shoulder pads is going to cause the head to fall back in that extreme sniffing position, which could destabilize a spinal fracture, a C-spine fracture, and paralyze your patient. We're going to remove it if it's a full face helmet. We're going to remove it if we need to manage our patient's airway. We're going to remove it if it's necessary to properly immobilize the spine. If they're little kids, they seem to want to put, little kids playing tackle football is not a great idea anyway. Like the grade schoolers, they have that enormous helmet, and they have that little head that they throw inside that helmet, and their little head squishes around all in there. It looks so cute, because sometimes when they run, it turns around backward and they fall down, and that's really funny to have on video. But if that little guy potentially has C-spine injury, that helmet and shoulder pads need to come off, because you can't just stabilize that head to the backboard use a CID and tape to stabilize that head to the backboard, because the helmet will be stabilized, but the little head will move around in there. So that's an indication for getting that out of the way. Patients in cardiac arrest, the helmet, shoulder pads come off, and we go to work, just like you know how to do from CPR. It takes two people, at least two, to remove the helmet. Contact medical control first, do a good baseline assessment. Even though you're taking something off, this is an intervention. So we need to assess motor, sensory, and circulatory prior to removing the helmet. We'll also need to document motor, sensory, and circulatory prior to removing the helmet. Then one person slides, so you have one person doing spinal stabilization, spinal immobilization. The other person slides, going up beside the jaws. You slide a hand up each side, and then like up each jaw, up beside the jaw and up. So you have a firm grip on the head, and then you maintain control of the head. You maintain C-spine while that helmet is while they slide that helmet off over your hands, and then someone at the top of the head could take C-spine from there, or you could go ahead and do all your spinal immobilization with your hands there. But that's how you do that. There's an alternate method to look at. It's just that's what I just described is what we're going to do. That alternate method, you remove the chin strap, you remove the face mask, and sometimes you watch things on the sideline at a boring football game, and you'll see they have an electric screwdriver down there, and they can change out a damaged face mask on a helmet. You could also take that face mask off to get down to in there to help remove so you take that face mask off, and then those jaw pads in a football helmet, you can remove those. So you pop those out, put the fingers in, and then you hold that, and they pull the helmet off. But if we're removing a helmet, it's usually a right now we need to get it off thing, and it's done by top left method here with getting those hands up under that full face helmet. Could do the same with the football helmet. I've done it before a lot of times. This one looks like they're maybe thinking about taking that face mask off. Anyway, that's how it's done. End of that lecture. If you have any questions, feel free to shoot me an email or a text, and I'll be happy to answer your questions. I will get those the outline summary for these chapters up on Blackboard for you, and that is all I have for this chapter.